Okay, well, welcome everybody that joined today. I actually have the pleasure to introduce Amanda. So Amanda Hurst, some of you already know her. She is part of our pediatric clinical pharmacy here at Sanford Health. And Amanda, or Dr. Hurst, received her Bachelor of Science in Pharmaceutical Science and Doctor of Pharmacy in North Dakota State University. And then after that, she went to practice pharmacist at the an infectious disease focused pediatrics pharmacy residency at Children's Hospital of Colorado. After residency, she actually stayed there for several years, 8 years, I think I counted. And her primary area of focus was antimicrobial stewardship and the network of care of pediatric clinical pharmacists. And basically, they're at Colorado, and those that you know, Amanda, you probably know this, but for those that is the first time you see her, she actually was instrumental in managing the antimicrobial stewardship program there. She basically, Children's of Colorado is a pretty significantly hospital. They had 1,500 antimicrobial orders per month. And she provided all the reports and all the recommendations and interventions to improve the use of antimicrobial therapy with an estimate projected saving cost of $300,000 per year, on top of improving healthcare quality. So we were really fortunately actually to recruit Amanda to our program, our pediatric and neonatal clinical pharmacy program here at Sanford Medical Center. She came in 2020, and actually I'm pretty excited, and some of you already know, but she will be a co-director of our antimicrobial stewardship starting March 2021 here at Sanford, so particular for Sanford Children's Hospital. So at that time, we were going to work along to improve antimicrobial use, diagnosis, stewardship, and improving the quality of care. Also, Amanda is not only an amazing colleague, but she's also a great mom. She's actually 36 weeks pregnant, and she's also pretty an accomplished scholar. She has more than 20 publications as a co-author, 6 publications as a first author in papers. I have 1 publication as a senior author as well, and many are related with antimicrobial stewardships. She has over 45 presentations to local, regional, and national meetings. So we're really happy to have her. I'm really excited to hear her talk. I'm really glad she's here with us despite her busy schedule and to give us this talk about common antibiotic prescription errors in pediatric patients. The floor is yours, Amanda.
Well, thank you so much for that introduction. As Dr. Lopez mentioned, I'm just going to be talking through a few of the common antibiotic prescribing errors we see in our peds population. I don't have any conflicts of interest to disclose before today's presentation. And after today, you will be able to recommend appropriate therapy for patients with both community-acquired pneumonia and refractory otitis, be able to highlight the differences between Augmentin products, and then also recommend appropriate Keflex dosing for treatment of UTIs, pyelo, and then our skin soft tissue infections. So to jump right into this, the first prescribing error, and perhaps you guys have also heard someone say this, I've heard providers say, I'm going to prescribe Ceftonir for treatment of CAP because it's cheap, it's tasty, and it's once a day. Now, my job here is to show you why this might not be the best option. So back in 2011, the IDSA published guidelines on the management of community-acquired pneumonia in our infants and children 3 months of age and older. Now, there's lots of beautiful tables in those guidelines, but once you get into the meat of the actual guideline itself, they do specifically state in there that no oral cephalosporin at doses studied in children provides activity at the site of infection that equals high-dose amoxicillin. So comparatively, those 2nd and 3rd generation oral cephalosporins that we have available to us only provide about adequate activity for 60 to 70% of our pneumococcal strains. And I'm going to show you more graphically what that means and where they're getting this information from. So to dig into this, the pharmacy side of me obviously wants to go back to pharmacokinetics and pharmacodynamics of those oral cephalosporins. When we think about the PK of those oral cephalosporins, we think of antibiotics in working in terms of either being time dependent or concentration dependent. And our cephalosporins are time dependent, okay? So when we're thinking about the PD, we have to think about the PK. And in general, our oral cephalosporins are very poorly absorbed. They have very high protein binding, essentially leaving our unbound drug at very low concentrations to work for us. And they, in general, have very short half-lives. And besides one exception, there's a limited accumulation in our tissues. Now, how that plays into the PD, as I mentioned, our target for our cephalosporins is time over the minimum inhibitory concentration, or the MIC of the organism. So what we need for these cephalosporins to work is their concentrations to be above that MIC for a certain percentage point of the day. It doesn't matter how high those concentrations are, as long as they're above that MIC. And some of you may be asking, well, what's our goal? You know, we don't have the best data to guide that in every single disease state that we manage with antibiotics, but in an extrapolation of adult pneumonia, the goal for a patient that is being treated with an oral cephalosporin that's well enough to be outpatient would be the goal time of those concentrations above the MIC, roughly 30 to 40% of the day. Now, if that patient is ill enough to be treated as an inpatient, our goal goes up. It's about 60 to 80% of the time, and that may be purely due to bacterial load. And then finally, if you have an immunocompromised patient, obviously they have nearly zero reserve. So our time over MIC, we need to be shooting for a goal about greater than 90% of the day. And when you think about other antibiotics, sometimes, depending on how they work, they have what's called a post-antibiotic effect. And what that means is after your concentrations of drug drop below that MIC, it still works, but not for the cephalosporins, and purely due to their mechanism of action. They work on the cell wall, and that cell wall is rejuvenated nearly 100% of the time of the day. So we don't really have any reserve there. Now, jumping into this may look a little busy, but I'm going to be presenting a lot of these graphs. So on this graph here, on the x-axis, we have a 24-hour day. And on the y-axis, we have concentrations of a specific antibiotic that are unbound. So these are the actual concentrations of antibiotics that are going to be working for us. So to graphically show why amoxicillin is better than these oral cephalosporins, I think it's important to look at these graphs. So this graph here is amoxicillin, and we are going to be looking at its concentrations in terms of the MIC of treating a strep pneumo isolate. So we have a sensitive strep pneumo isolate here with an MIC of 2 or less. So that's represented here by this black line. And so clearly our antibiotic amoxicillin is only working for us when that concentration is above this black line. Now, as you all know, there's many different ways to dose amoxicillin, and so each of the lines represents a different dosing schema. So the red line here is amoxicillin high dose, which is 90 per kilo per day, divided 3 times a day. And then the blue line represents amoxicillin high dose divided twice a day, which is 90 per kilo per day divided twice a day. So this is what is in our currently recommended guidelines here at Sanford Children's. And then finally, low dose is 45 per kilo per day divided 3 times a day. So as you can see here, if we are shooting for at least 30 to 40% of the time of the day for a patient who is an outpatient, if we know we have a sensitive strep pneumo isolate, that amoxicillin high dose divided twice a day is just fine. And so this looks great for amoxicillin, and obviously it's because we have a lot of good PK pieces for this drug. So it's very highly absorbed, nearly 90%, and it's very, very low protein bound, only about 20%. And unfortunately, with pretty much any of our oral beta-lactams, they have a very short half-life. So this is basically the only piece that we're running against. Now, let's say we know we have an intermediate strep pneumo isolate. You know, these here at Stanford are relatively rare post PCV13, which we'll be talking a little bit later. But an intermediate strep pneumo isolate has an MIC of 4. So that black bar moves up. And essentially what that means is our oral antibiotics may not have as high of serum concentrations to maintain above that MIC for as long of the day. So you can see here that our time above MIC drops quite significantly. So the high dose divided TID regimen will get you the best bang for your buck. As you go down in dose and frequency, you lose that time over the MIC. Now let's start comparing this to our available oral cephalosporins. So what I have graphed here for you are our oral second generation cephalosporins. This would include cefuroxime and cefprozil. Now, a sensitive strep pneumo isolate for against these two antibiotics would have an MIC of 1 or less. So we can see that graphed out here. And again, the concentration of our antibiotic just has to be above this black line. But you can already see that our time above MIC, even for a sensitive strep pneumo isolate, is much lower than the over 50% we saw with amoxicillin. So even for a sensitive isolate, cefprozil only has a time above MIC of 33%, and cefuroxime is 21%. And you'll see here, this is a lot of the reason why. So cefuroxime at best is only 50% absorbed and has about 50% protein binding. Cefprozil is much better absorbed, so you'll see why we have higher peaks here, but its protein binding is still at 36%. So let's say we have that intermediate strep pneumo isolate. Our cefuroxime doses barely make it over the MIC of that organism, only 2 hours out of the day, which is 8%. And our cefprozil is at 17%. So we are definitely falling short of those goals of at least 30 to 40% time above MIC in a day. Now switching to our third generation oral cephalosporins, we have cefdinir and cefpodoxime. And again, we have the sensitive strep pneumo isolate, and its MIC for this generation of cephalosporin is an MIC of 0.5 or less, which is graphed out here. Now, I kind of wanted to go through the different cefdinir dosing that's out here. This first red line here represents double the manufacturer recommended dose. This is actually was used for several years by some practitioners out at Children's Mercy in Kansas City. So this is why I graphed this out here. But cefdinir high dose twice a day is actually 14 per kilo per dose twice a day. So double the manufacturer recommended dose. And then standard dose divided twice a day would be our manufacturer dosing. So that here is 7 per kilo per dose twice a day. And then standard dose once a day would obviously be 14 per kilo per dose once a day. So when we take that into consideration, if you just look at our cefdinir PK stats over here, only at best, it's 25% absorbed. So we're already starting behind the 8 ball, and it is very, very highly protein bound, 73%. So we don't have a lot of active drug for us in our system with oral cefdinir. Now, cefpodoxime is slightly better. It's 50% orally absorbed and has much less protein binding here. So you can clearly see that cefpodoxime, although again, lower than amoxicillin time above MIC for a sensitive strep pneumo isolate, it pharmacokinetically is superior to cefdinir. Now, this is kind of interesting to me, and if you take anything away today, I really hope you remember this slide. If we were to have an intermediate strep pneumo isolate, that MIC is 1. And you can clearly see here, even using double the dose that's recommended by the manufacturer of cefdinir, we don't get any time above the MIC of this organism. So definitely not a step up of amoxicillin therapy. Now, ceftriaxone, we still do maintain about 4 hours out of the day with an intermediate strep pneumo isolate, but again, that time above MIC is about 17%. So how do we fix this prescribing error? Well, first and foremost, if you have a fully immunized child, go with the guideline recommended dosing. We're going to be using that amoxicillin 90 per kilo per day, and we're going to divide it twice a day. If they're ill enough to require IV therapy, that's when they'll be getting the ampicillin at the doses listed there. If you have a patient that's not fully immunized, we will be broadening our initial therapy to include coverage of H-flu and MCAT, and that would include oral augmentin. But again, you'll see that higher dose, the 90 per kilo per day, and that's to cover that strep pneumo. And then for IV, they would be using ceftriaxone. So you might be asking yourself, well, this is all fine and good, but what if my patient has a penicillin allergy? Well, first, as many of us know, our children that are labeled as penicillin allergic are not always real. And if they carry that label for the rest of their lives, they are suboptimally treated for multiple infections. So it's important to get that cleared up. But if you were to have a true penicillin allergy, the guidelines recommend oral ceftriaxone, cefprozil, or cefuroxime. Cefdinir does not come up in those guidelines unless you have a documented gram-negative pneumonia. And it is clearly because it is inferior in the treatment of strep pneumo. And of course, on the inpatient side, or if they need IV therapy, we'll be using ceftriaxone. Now, moving on to the second prescribing error, my patient failed amoxicillin and augmentin for otitis. So I'm going to prescribe a smattering of any of these oral cephalosporins. And what I want to get across is that IM ceftriaxone or IV ceftriaxone is not equivalent to any of those oral cephalosporins. So to kind of get into this a little bit, I wanted to talk about the resistant mechanisms of the common organisms we see causing acute otitis media, because I think understanding this will help decipher your treatment plan for some of these patients. So the most common bacterial cause, or at least in years past, has been strep pneumo. And what strep pneumo, it's a gram-positive organism, and what it tends to do is modify that penicillin binding protein that amoxicillin or any of your oral cephalosporins bind to, just slightly. Then it can also modify the ribosomal target. So that's what we're kind of thinking about when we're trying to treat with a macrolide like azithromycin or even clindamycin. And then finally, with our other two organisms that cause otitis, we have our gram-negatives. We have our Haemophilus influenza, and then our Moraxella catarrhalis. So both H-flu and MCAT, because they're gram-negative, they like to produce the beta-lactamases. So once an organism produces a beta-lactamase, it renders amoxicillin ineffective. This has nothing, you would need augmentin, you would need that beta-lactamase inhibitor to cover these two organisms in that case. There's a variable expression of beta-lactamase production in H-flu, about anywhere from 30 to 50%, depending on where you are in the country, but roughly 100% of MCAT produce that beta-lactamase. They also, because they're gram-negatives, can go through efflux changes for our macrolides, and then also have decreased targeted affinity, as in the case of Bactrim. So jumping into this, we have the American Academy of Pediatrics guidelines from 2013 that recommend, initial treatment with amoxicillin for the majority of patients, and then augmentin for patients if they've had amoxicillin in the past 30 days or if they have otitis conjunctivitis syndrome. And some people may say, well, yes, this is recommended first line, but I see there's alternative treatment options right next to these that include cefdinir and some of our other oral cephalosporins. And what I want to get across is that using ceftonir is a step down in therapy compared to Augmentin, especially up front. And if the graphs earlier didn't demonstrate that, we might have to go back. But I just want people to realize that alternative doesn't always mean that it's equal, and does definitely not mean that it's better. And just like the pneumonia guidelines, it specifically states in these otitis guidelines that alternative antibiotics vary in their efficacy against otitis pathogens. And they specifically call out strep pneumo here and say that recent US data on the in vitro susceptibility of strep pneumo to ceftonir and cefuroxime are 70 to 80% compared with 84 to 92% of amoxicillin. And again, that's likely due to the inferior pharmacokinetics that we see with ceftonir. So I wanted to show this a little bit too when we're thinking about, well, my patient's failing, what could be going on? So I like to bring up this study by Carr and his colleagues. This was published back in 2017. This is from New York. This is one of the practices that still routinely uses tympanocentesis and cultures of otitis patients, which is really great on the study perspective. But they published back in 2017 the epidemiology of acute otitis media in the post-pneumococcal conjugate vaccine era. And why I want to kind of bring this up is we are seeing a change in the bacteria that are causing otitis. So if you look at panel A here, this demonstrates the percentage of otitis cases caused by MCAT in green, H flu in red, and strep pneumo in blue from 1995 to 2016. Now, 2 time points that I kind of want to point out to you guys is the year 2000, we had the introduction of PCV7. So that would be right around here. And then in 2010, we had the introduction of PCV13. So you'll see these huge decreases in the percentage of strep pneumo isolates, likely due to vaccination. So with that, you'll see as time has gone on, the overall, if we look at 2016's data, the overall amount of otitis cases caused by strep pneumo were just above 20%, as compared to 60% caused by H flu, and then the rest caused by MCAT. Now, they decided to look at this data in a slightly different way. They looked at, what is the percentage of patients that have each of these pathogens in the pre-PCV era, then after PCV7, and then after PCV13. And you'll clearly see there was a statistically significant decrease in the number of otopathogens causing otitis, number of strep pneumo cases of otitis in the post-PCV13 era. There statistically wasn't a difference in H flu, but you can see the statistically significant increase in those caused by MCAT. So when we're thinking about this, we know that 100% of MCAT will not respond to amoxicillin. And roughly here at Stanford, roughly a third of our H flu will also not respond to amoxicillin. So how do we fix this? Well, going back to the guidelines, if we have a patient that starts on amoxicillin for the treatment of otitis, if they fail, we would step up to Augmentin. Now, if we would have a patient that was treated first line with Augmentin, you might be asking yourself, well, we're covering for strep pneumo, we're covering for H flu, and we're covering for MCAT already. So what could be going on? Well, in the guidelines, they recommend stepping up to IM ceftriaxone, and this is 50 mg per kg. And in the table here, it says for 3 days. In practice, this can be for 1 to 3 days. They've never compared 2 days to 3 days. But what you would be getting additional coverage for here would be more of a resistant strep pneumo, because you can see resistance to the penicillins while you still maintain activity with your cephalosporin. Now, moving on to our third prescribing error, it's the dose of amoxicillin or Augmentin used for sinusitis. So I really don't blame us here. We have two different guidelines that dictate treatment of sinusitis, and they kind of say different things, even though they cite the same information, which is kind of funny, but we have the IDSA guidelines that were published in 2012, and then we have the AAP guidelines that were published in 2013. So the IDSA guidelines, of course, this is in patients who have failed the watching and waiting and have a true bacterial sinusitis. As many of us know, treatment of sinusitis immediately with antibiotics is not indicated, and usually is viral in nature. But if we do decide, antibiotics are indicated in these cases, Augmentin is recommended by the IDSA guidelines, whereas the American Academy of Pediatrics states, well, you can maybe use amoxicillin, and you can maybe use Augmentin. They suggest using Augmentin in patients that are in child care, that have received antimicrobial therapy in the past 30 days, and those patients that are less than 2. So essentially patients that have different risk factors. But they both recommend using a dose of 90 per kilo per day divided twice a day. And as you guys are probably now aware, we use that higher dose, that 90 per kilo per day, to help with the strep pneumo piece. Once that strep pneumo starts becoming resistant, it just changes the conformation of that penicillin binding protein. And the only thing we need to do is increase that dose to overcome that conformational change. So both of these guidelines suggest using that higher dose in areas that have strep pneumo resistance or strep pneumo penicillin non-susceptibility of 10% or greater. Now, they do have options as well for patients that have penicillin allergies. So when I talk about sinusitis, I think we need to be talking about too, like how can we figure out which patients need amoxicillin, which patients need Augmentin, and going by those guidelines. And I bring up this same slide that we just talked about with otitis, because the bacteria milieu that causes sinusitis is shared by otitis. So you can extrapolate a lot of the otitis media guidelines, or the otitis media information for our sinusitis patients. So with that being said, we're starting to see, as you know, a trend of decreasing strep pneumo, and we're seeing an increase in influx of MCAT specifically. So this would potentially be why you would want to choose Augmentin first. Overall, we're seeing a decrease in strep pneumo. So if we want to be treating for the organisms that are becoming more prevalent, those two, H. flu and MCAT, can produce that beta-lactamase. So amoxicillin would be rendered ineffective in those situations. But then you can kind of flip the other side of the coin and be like, well, can we use amoxicillin? So I think this study and it was really more of an opinion piece published by Dr. Ward back in 2018, looked at the actual bacteriology of acute otitis media from several different studies in the post-pneumococcal vaccine era. So what she found was that strep pneumo prevalence, it's only causing about 25% of our otitis media, and hence potentially you could extrapolate to say about 25% of our sinusitis. H. flu is up in about half, causing about half, and MCAT is causing about 15% with a smattering of few others, sterile and group A strep. So if you take this into account and then also superimpose our H. flu sensitivity rates here at Stanford in Sioux Falls, our ampicillin susceptibility to H. flu, essentially meaning beta-lactamase negative, is 66%. So a third of our H. flu isolates are going to be AMP resistant. So if we take all of this into account, if you have a true bacterial sinusitis, the chance of a documented resistant pathogen requiring Augmentin is about a third. So keep that in the back of your head. So then I want to go through the actual dosing. So why do we want to still use this high dose? So again, this researcher, Dr. Richter, out in Cleveland Clinic, looked at nearly 1,500 strep pneumo isolates from October of 2012 to March of 2013. So after PCV13 was added. So what she found was that over roughly 35% of isolates still had MICs, which you'll see here, that were penicillin non-susceptible. So anything 0.1 or greater is considered to be penicillin non-susceptible. So 65% were true of these strep pneumo isolates were sensitive. So this would suggest that overall, we are still seeing some strep pneumo resistance despite these vaccines. Now, looking at a different study from Carr, he looked at the specific strep pneumo strains that we're seeing after this PCV13 that came out in 2010. And what he found was that we have roughly 25% of our isolates are still strep pneumo resistant. So I think still using high dose may be the way to go until we have a little bit more information about what other strains of pneumococcus are coming our way and what their amoxicillin or penicillin susceptibility profile will be. So continue to use that 90 per kilo per day and either amoxicillin or augmentin, but stay updated on the changing trends in the epidemiology, specifically with strep pneumo. If we continue to see a decrease in resistance, we may not need to use that high dose, that 90 per kilo per day anymore. And then, of course, just personalize the choice of amoxicillin or augmentin to each patient. You could consider those risk factors for H flu involvement. You know, do they attend daycare? Do they have recurrent otitis? Are they less than 2? Did they have antibiotics in the past 30 days? You may want to be more broad in those patients. And then I kind of like to put it in these terms too, because I feel like sometimes the choice between amoxicillin and augmentin is not heavily weighed. So I like to think about the adverse effect profile differences between amoxicillin and augmentin. The rate of diarrhea for amoxicillin is 1%, and it's reported at roughly 3 to 14% for augmentin. So if we were to transition that into a number needed to harm, it would be 8 to 53 patients, which I don't think is astronomically high number of patients to see to harm by choosing augmentin one time. Now, another prescribing error that we see quite frequently is using the wrong formulation of augmentin. You know, and the culprit, of course, is the 95,000 formulations that we have of augmentin on the market. And that might be a little bit of a stretch here, but I threw it into a table here to more show how many different options there are. So when we talk about augmentin formulations, we talk about them in terms of the amoxicillin clavulonate ratio. So the concentration of amoxicillin to clavulonate. And we have a 2-to-1, 4-to-1, 7-to-1, 14-to-1, and 16-to-1 formulations available to us. Now, the issue with this is some of these have both tablet and suspension formulations, while others only provide tablet formulations or only suspension formulations. The two that we most frequently encounter in the pediatric world would be the 7-to-1 and the 14-to-1. So the most commonly used would be the 457 milligram per 5 ml suspension, which is also equivalent to that 875, 125 milligram tablet. And then we also have the 14-to-1 suspension formulation. This is the 642.9 milligram per 5 ml suspension. And this stands for ES extra strength. So be keeping that in the back of your heads as we go through these next slides. And then the 16-to-1 formulation, although not heavily used in peds, it also is that high dose formulation, the 1,062.5 milligram extended release tablet. So I think it's kind of interesting. I think no matter where you go, people always struggle with augmentin due to the number of available suspensions there are. Specifically for peds. There was one freestanding children's hospital that removed all suspensions other than the 600 per 5 due to the number of errors they were seeing. So the risk with this, and let me just go back one slide, is we have these higher amoxicillin clavulonate ratio products to prevent the overdose of clavulanate. Once you start pushing your amoxicillin doses, you don't necessarily need or want, for that matter, as much clavulanate in those products. So the 14-to-1 and 16-to-1 products allow you to use higher dosing of amoxicillin without overdosing on clavulanate. So when you're thinking about picking the correct formulation, the first thing you need to think about, don't pick your formulation first. Pick your milligram per kilo daily dose first, because that's really what dictates your desired ratio. Then choose your product, and then as a double check, calculate that clavulanate dose. And as a general rule, this is really hard to find. I had to dig through papers from 1970 to find this clavulanate max, but the general rule is a max clavulanate dose of 10 mg per kg per day. And higher doses of clavulanate may cause more GI side effects. So we want to limit that if we can. So if we were going to start with picking our mg per kg per day dose first, if our desired daily dose is that high dose, the 90 per kilo per day, we need to be choosing those high dose formulations, the 14-to-1 or the 16-to-1. That 16-to-1 product, the XR tab, is only approved for use in kiddos greater than 12 and greater than 40 kilos. But we do have a suspension formulation available, and then that XR tab. Now, if we were going to do a lower dose of 45 milligram per kilo per day, that's when the 7-to-1 formulation would come in. So that would be the 457 per 5 or that 875 125 tab that we frequently see. So you might be asking, well, where are all of the other ratios? Where are all of our other products? And why aren't the 4-to-1 and 2-to-1 concentrations on here? The 4-to-1 formulation is really only listed in neonatal dosing. Other centers do use different augmentin products in this population, but it's relatively rare that we use it in the NICU population anyway. But that is the only place it shows up. And then the 2-to-1 formulation really shouldn't be used for pediatric patients less than 40 kilos. And I would argue that it's not really indicated for anyone. So if you're choosing a few of those products, just triple check your work and make sure you're selecting it for the right reasons. So I like to bring up these tricky situations because not everything can be straightforward, right? So let's say you have a 35-kilo, 10-year-old unimmunized female with CAP, and she refuses to take suspension, and she wants tablets to treat her CAP. So if we're treating CAP in this patient, because she's unimmunized, we should be using augmentin, and the guidelines would recommend that we're using 90 per kilo per day with a max of 4 grams a day. So if in a perfect world she was going to take suspension formulation, we would just use that 90 per kilo per day. We would use the ES suspension, and we would only get about 6.4 mg per kg per day of clav. Well, if she's refusing that suspension, we kind of have to go with a different product. And unfortunately, that ES suspension does not have an oral equivalent. The closest thing to it would be the 16-to-1 formulation, that augmentin XR tab. So that XR tab is only approved for kids 12 and older, I believe, and greater than 40 kilos. So she doesn't quite make it, but let's just say we're going to use this off label and see if it works. So if we were to do augmentin XR 2 grams twice a day, that would give us just over 110 mg per kg per day of amoxicillin and would still keep us below our clavulanate max. Now, I've also seen people use augmentin XR 1 gram BID in this situation, but this would be a underdose of our amoxicillin. We'd be roughly 60 milligrams per kilo per day, and then 3.6 mg per kg per day of clav. Now, another option would be to use the 875 125 tab. This is a 7-to-1 formulation. If we were only to do that twice a day, they would get 50 mg per kg per day of amoxicillin and 7 mg per kg per day of clav. Now, we can kind of switch it up a little bit and do it 3 times a day, and it would get us slightly closer to our goal. We would be at 75 mg per kg per day of amox, but we would overdose on our clav there at 10.7 mg per kg per day. So I just post this as a question, which one would you choose? And, you know, I've seen them all used, and in these situations, I think it's really down to the patient and how convinced you are, you know, how bad is this pneumonia? How bad do we want to cover strep pneumo? Because if we would want to cover strep pneumo, this might be the best option we have out there, the Augmentin XR 2 grams twice a day. Because if we have an intermediate resistant strep pneumo isolate, because when do we ever know what's causing our community-acquired pneumonia? Hardly ever. We would be severely underdosing our amoxicillin on this part. Now, at my other institution, we would frequently go to this option because it provides relatively similar amounts of amoxicillin and clavulanate. But if this patient had, you know, diarrhea, this definitely would make this worse. And then the final thing that I was going to go through is the dose and frequency of Keflex for pretty much everything. And again, I feel like the culprit here is really that our dosing references are really broad and nonspecific. So this is just a snippet here from LexiComp, and it's actually gotten a lot better since 2020. But you'll see here that for a mild to moderate infection, they recommend 25 to 50 mg per kg per day. And they say, you know, divide it every 6 to every 12. Well, that's a big difference. But they finally, thank goodness, added this note at the end that says, at these daily dosing less frequently than every 6 hours may be inadequate for many Staph aureus isolates. And we'll go through what that means and why. But that did not live there. That note did not live in LexiComp until 2020. The other culprit is that we don't always know the pathogen, and our MIC is way different for a group A strep than for Staph aureus. Group A strep has much lower MICs than Staph aureus. And I think the other piece is not always being sure of the diagnosis, specifically when you're treating a UTI. Is it just a simple UTI, or is it, do we have higher tract disease? Do we have a pyelonephritis going on? And then finally, not completely understanding the PK and the PD of Keflex. So most commonly, as you guys know, we treat UTIs and skin soft tissues infections with Keflex. We can also use it for treatment of strep pharyngitis in those pen allergic patients. We also use it for osteo transitions here on the inpatient side. The good thing about Keflex, this is the one oral cephalosporin that I won't give a hard time. It has really high oral absorption, roughly 90%. It has low protein binding at most 20%, and has really good tissue and bone penetration, which is why we can use it for those osteo patients that I mentioned. It's also renally cleared, which gives us a leg up in treatment of UTI. The unfortunate part of Keflex is that it has a very short half-life, and it's actually the shortest of all of our oral cephalosporins. At best, its half-life is an hour. So when we're jumping in just for Keflex and treatment of UTI and pyelo, the dosing and the frequency of your Keflex should really be dependent on your diagnosis, because it should be different for UTI than it should be for pyelo. But this is one of the instances where I'm definitely glad I'm a pharmacist and I'm not a physician trying to decipher if my patient has just a simple UTI or pyelo, mostly because there's no real clear definition of upper versus lower tract disease. And oftentimes we use those non-specific signs to differentiate, you know, do they have fever and chills? Do they have nausea and vomiting? In our older patients, do they have flank pain? But the scary part is up to 25% of kids without classic signs and symptoms of pyelo actually have upper tract disease. And then on the flip side, up to 50% of kids who have flank pain don't actually have pyelo. So it's one of those diagnostic conundrums that I'm glad I don't have to decipher from. So one thing that we frequently hear is that, you know, Keflex is concentrated in the urine. So twice a day dosing is fine. And it's true. Keflex, because it is cleared in the urine, it has much higher concentration. So you'll see here, if we look at peak urine concentrations, after a 250 milligram dose of Keflex, your concentration in your urine is 1,000 mics per mil. as compared to 7.6 mics per mil in your serum. So it is heavily concentrated there, but it is time dependent. This is a time dependent antibiotic. It's not a concentration dependent antibiotic. Now, so what that would mean was you kind of have to think about your urinary frequency in these cases. So for the entirety of the time that this Keflex is in the urine, it's going to be above the MIC of the organism, right? But if you have a child, you know, let's say that is urinating 6 to 7 to 8 times a day, you're going to have some decreased exposure because the bladder will empty. So we have to think about that. So with that being said, 3 times a day dosing is likely adequate for treatment of UTI. But when we're thinking about treatment of pyelonephritis, Keflex is not concentrated in the renal parenchyma. You know, it's likely more similar to your serum concentrations than your urine concentrations. So optimally, 4 times daily dosing would be recommended, and the higher doses would be recommended for treatment of pyelo. Now, and this is just another graph, kind of to mimic those strep pneumo graphs that we were looking at earlier. So this represents a sensitive E. coli isolate. They have an MIC of 8 or less here. So this is this black line. And then we have Keflex dosing, either divided 4 times a day or 3 times a day. Now, if we're thinking about treatment of pyelo, again, these concentrations are going to be close to what our serum concentrations are. So our goal time above MIC is right around 30% if we were to extrapolate, and you would only get that with 4 times daily dosing. Now, when we're thinking about pyelo versus UTI, again, dosing is different. For UTI, 50 to 100 per kilo per day divided 3 times a day is likely just fine. And there was a recent Sanford guideline that was published back in August for treatment of UTI that recommends 100 per kilo per day divided 3 times a day. Now, for pyelo, you may want to push a little bit more for 4 times daily dosing because, again, although it is cleared renally, you may want those higher renal parenchymal concentrations of the drug. Now, when we're jumping over to treatment of skin soft tissue infections, I just bring up the 2014 IDSA guidelines. Now, Keflex dosing should be highly dependent on the organism we're treating. As I mentioned, Staph aureus has much higher MICs than group A strep, but oftentimes we don't know what it is. So in cases of staph and strep, you'll kind of see a recurring theme. When there's strep involved, you may start seeing recommendations for less frequent dosing. So you'll see here the guidelines recommend generally 50 mg per kg per day in 3 or 4 divided doses, so TID or QID. Now, if we have a documented Staph aureus infection, this is when they suggest dividing it 4 times a day. Now, and I get this, I'm a mom, like my patient is not going to take Keflex 4 times a day. It's just not going to happen. Well, I think we need to start thinking about like weighing the benefit and the risk in these certain situations too. So Staph aureus MICs are much higher than a group A strep, but we don't always know if, you know, especially in non-purulent cellulitis, is it actually Staph aureus or is it group A strep? So usually we empirically cover for both. And when we're thinking about, you know, graphically, which I'll show on the next slide, our concentrations in our skin are probably around unbound serum concentrations. So if we were to look at a sensitive Staph aureus isolate, it has an MIC of 2 here. This looks really busy, but these are all of the different dosing options that we can use. So if we were to use 4 times daily dosing of Keflex at a dose of 25 per kilo per dose, we would have nearly 60% time above the MIC. Now, the guidelines recommend that 50 mg per kg per day divided 4 times a day, right? This would be about 50%. So if we would decide to do 50 mg per kg per day and divide it 3 times a day, that drops us quite a bit. So if I were trying to choose Keflex for a family that I knew was not going to be compliant and they might be compliant with TID dosing, and I knew I wanted to stray from the guidelines, you can look here. You're relatively closer if you do this high dose divided 3 times a day dosing. So although I will say, we should probably be doing 4 times daily dosing. If you feel like your patient is not going to take that, perhaps we need to, move up to the 25 per kilo per dose recommendation and do TID instead. But frequency of dosing is likely more impactful than the actual dose or the max dose. So of course, when we can do QID, and the national guidelines support that. But as I mentioned, if you're insisting on TID dosing, consider that higher dose. All right, you guys, that's all I had. Do you guys have any questions?
That's great. Thanks, Amanda. That was pretty good. A pretty nice review, I guess. I think Dr. Zelstra, he has a question. He's in the chat. Could you old school it and do the 875, 125? I guess he's talking about amoxiclav. So the amoxicillin component will be 875 milligrams, and the clavulanic component will be 125, and add amoxicillin to it.
That's interesting. We've brought that up too. You technically could do that as long as the parent would understand that piece. The only drawback to that would be on the outpatient side, they would have 2 copays for those antibiotics, since they would be 2 different prescriptions. So we have come across that before. And just the complicating feature of being like, well, you only need 5 mils of this drug plus this on top. But yes, you definitely could do that. Yep.
People can also write their questions in the chat or just open their microphones. So Amanda, since we have you here, can you, especially the ones that are less familiar with antimicrobial stewardship, and now that you're going to have dedicated time to it here at Children's, could you kind of like give us a quick and dirty of what is the role of the antimicrobial stewardship beyond only like dosing of antibiotics and prescription?
Oh, sure. Well, and I'm sure a lot of you know, but antimicrobial stewardship is one of the requirements by Joint Commission. Lots of state boards of health also require antimicrobial stewardship programs. But what we're finding and why we're finding that antimicrobial stewardship is so important, especially in our pediatric and neonatal populations, is that overuse of antimicrobials leads to long-term detrimental effects in these pediatric patients. And it's not just with resistant organisms, because of course, when we think about stewardship, we think about, let's decrease the resistance so we can preserve our antimicrobials. But what we're finding is overuse of antimicrobials in pediatric patients, because of the impact on our microbiome, we have increased risk of atopic diseases along with obesity later in life. So these patients that are being, inappropriately treated become much more sick adults in the future as well. So the importance of stewardship is not always just dosing or, choosing the right antibiotic, but it's really preserving those antibiotics for the patients that need them, and to do that most optimally. So, I mean, stewardship, I think a lot of people think of it as being, the cop of antibiotics, but it's really just trying to work with everyone and make sure that the antibiotics that we're using are appropriate for that specific patient.
Great, thank you. I think Dr. Candice Nelson, one of our primary care providers, she has another question. The new guidelines recommend 5 versus 7 versus 10 days of antibiotic for acute otitis media. What do you recommend?
So I personally, the guidelines haven't been updated in a while. So the guidelines, the AAP guidelines still say 10 days. However, there have been reports on shorter days, 5 or 7 days. And I think, as we start choosing the right antibiotic, the next thing that we're working on stewardship-wise as a whole is improving the length of therapy. And it's likely appropriate for several patients, as often we know that these patients are overtreated in general and oftentimes are viral in nature. So I don't know if you have more of an opinion yourself, Dr. Lopez, but I think in the future, when these guidelines are updated, we will have shorter courses specifically for those lower risk patients who are older, who may have unilateral otitis, et cetera.
Yeah, basically there was one paper in 2016 which was not concomitant with the guidelines that was from the group at Pittsburgh. Alejandro Oberman was the first author in New England Journal of Medicine, where he clearly showed that those older kids, like you say, like the older kids that may be older than 2 years of age may benefit from longer courses, and usually 7 days will be the length, 5 to 7 days, but more towards 7 days. And why I say more towards 7 days, because Ellen Wall, which is a famous acute otitis media and sinusitis researcher, published another paper that basically for those that had severe like bilateral otitis media, 7 days was better than 5 days in terms of outcomes. But something that is really highlighted in that paper from 2016 from Alejandro Oberman that was published in the New England Journal of Medicine was that he clearly showed that the younger kids less than 24 months of age do have better outcomes when they were treated exclusively for acute otitis media for 10 days. And I typically use that as my reference. Younger kids less than 24 months of age, I give them 10 days. I rarely diagnose otitis media, but when I see it, I give them 10 days. And those that are between older than 2 years of age, I'm shorter on course, which is 7 days. And all that said, that is if it is, of course, outpatient therapy. Inpatient therapy, if you give ceftriaxone, can be actually 1 day of therapy, but no more than 3 days. So that would be my take on that. Dr. Seltzer has another question. So I heard similar recommendations as the first strep pneumovax, so the Prevnar 13, thought that Haemophilus influenza was going to be prevalent. Then back to Amoxi until Pneumo 13. Do you expect that other strep pneumonia strains to return to the prevalent again and the H flu increase will be temporary again? So basically he's saying once we change the vaccine generation, if that put pressure on the vaccine, do you foresee seeing other strains coming up?
I do. That's why I'm a little bit hesitant to specifically state, oh, everybody needs to use Augmentin again, because I'm holding out for those other non-vaccine covered strains to be back again. And who knows how long to wait for that. I mean, Prevnar 13 has been out for over 10 years now, so maybe I'm just waiting a little bit too long, and maybe I'm just a little old school, but I do feel like those strep pneumo strains will be coming around again, and we just need to figure out, are they going to be ones that are resistant, like our 19A was, or are they going to just have the sensitivity profile of our strep pneumo sensitive strains?
Yeah, just to add in, Dr. Seltzer is a sub-investigator on this study. So there is a study that now concluded to accurate, which is the PCV20. So basically the study is a study from the pharmaceutical company Pfizer. What they are testing is their Prevnar 13 against their PCV20, so 13 serotype versus 20 serotypes. And the reason why is that is when you put pressure on the bacteria, all their cousins of strep pneumonia come out and play. And so we'll see what happens. I do agree with you, Amanda, that may be the case, that once we put more pressure with the vaccine for certain strains, other ones will come to play as well. Any other questions? Well, we're almost at the top of the hour, and actually Amanda and I have to meet to do antimicrobial stewardship on the hospital. So I'm gonna let everybody go. This was great. Thank you, Amanda, for your time.
Thank you, everybody.